Okay, thank you so much, Gillian, and thanks for the introduction. Um, this webinar series has an amazing lineup of topics and presenters. And as your first, let me just move this out of the way. As your first speaker, I kind of feel like I just need to lay the groundwork for what's going to be coming over the course of the next year. Somehow, when we mentioned my background, we didn't mention that I'm in the College of Public Health, which is where the Center for Social Marketing is located at USF. So, what I'm going to talk with you about today is some communication fundamentals to begin. And these are some things that maybe we tend to take for granted unless we studied communication. Very basically, communication is about sending a signal of some kind. And in the picture, we have a sender, and he's making sound waves, which are the medium. And those travel through a channel, which is this little string between the two cans. To make it meaningful and not just noise, the sender has used a symbolic system or language to encode his thoughts. And that receiver has to be able to decode that message in order to understand. Um, the way you know that your communication has been successful is when that receiver responds in a way that you expect. So I suggest that all communication is behavior change communication, or at least meant to affect behavior. Because otherwise you'd just be waving your tail around and there wouldn't be any response from it. But a major problem or challenge in communication of any kind is how it rarely works the way we hope. Um, Osmo Wio was a Finnish communication scholar, among many other things. And he has a set of ideas that are akin to Murphy's laws, but they're particular to communication. And I really like them a lot. The first one is that communication rarely works except by accident. But even more importantly, and I've seen this come up so many times in my personal life, as well as, of course, professionally, if a message can be understood in different ways, it will be understood in just that way that does the most harm. And of course, the more communication there is, the more difficult it is for communication to succeed. So we have a lot kind of working against us, and I think we've seen that in the past few years, extraordinary amount, that we're competing against a tidal wave of dis and misinformation. We might say misinformation out there is largely due to people misunderstanding or somehow getting the most harmful interpretation of communications that we put out there. But what's really important for us to remember is that it's all about emotion. People tend to be more attracted to conspiracy theories when some other important psychological need is not being met. People need to see and be seen, and they need to feel safe and secure. So, no matter what else we are doing with our health communication, we need to be keeping these things in mind at all times. That this is sort of the underlying, if I'm going to say the foundation of all foundations, this is really the underlying foundational point that I hope that you take away. Now, the competencies in public health communication are meant to help us be more successful than WEO predicts or, than WEO predicts. And this particular set that I am sharing with you right now comes from our colleagues in Canada, specifically Jennifer McWhirter and her colleagues. I helped them when they were doing a Delphi process to try to come up with their competencies. Of course, we also have competencies in public health communication, but I really like the way this is laid out in their diagram. I particularly like that it centers values and equity and culture and community centered, along with our theories and evidence as being the foundation of health communication. Walking around the outside, you're going to see many of the skills and processes that we think are part of our field. And as Gillian mentioned, I think you're going to be hearing a lot more about these over the course of the year. But you could just take this slide and that would be the whole talk, and I could just stop right now and take your questions. And I'm so tempted to do that, but I won't. Okay. what I consider to be foundational to public health communication is our planning process. And as you know, in public health, we begin with that there's evidence of a problem, but also that there's something can be done to lower exposure or risk to that problem. So from there, as a health communication person, we can then follow the basic steps in the planning model that I think if you ever studied health communication or health education, you recognize is coming from the National Cancer Institute's health communication process model. There's a book called The Pink Book, which I'll share with you at the end of this talk, and how to go about doing health communication professionally. So the first phase they call planning and strategy development, which is where we're figuring out whom we're trying to reach, what can they do to improve and reduce their risks, and what communication approaches will work best, as well as possibly making our partners, getting our partnerships lined up. We then move on to creative development, implementation, and evaluation. So this is a very basic model. I'm going to break this down a bit over the next few slides with you. So this is just the whole first phase of the NCI model, which is when you're doing your planning and strategy development. And most of us spend most of our time in this phase of the process. And since I'm going to cover each of these in a minute, I'm not going to read down this slide for you right now. Does it always go like this, quite so linearly? Well, of course not. Particularly, you might start with the partners, and if your audiences, particularly if what you're using is a co-creation process. So this is just a model among the many models that we have in public health, but I hope it's a super model for you. All right, so beginning at what we called our step one in the planning process, we are trying to analyze the problem and where it lies in the ecological model. And I'm pretty sure that in public health, we all start at one point to dream the socio-ecological model. We do try to focus as upstream as possible when we're planning interventions. So at the policy level, or trying to affect environmental conditions or other social determinants. In health communication, we tend to think about this model more holistically, realizing that we probably will need to have some form of communication at every level in order to achieve a public health outcome. So yes, for us in public health communication, it does sometimes feel like everything everywhere all at once. And I would say that the tools that I'm going to be sharing with you right now is to help you try to avoid the chaos of it all and have some sort of a systematic way in order to say where and when and what your communication is doing. So the next step in our process model here for planning is we're selecting our intervention. And as I mentioned before, we think that we have a public health problem well defined and we have an evidence-based intervention or more than one. Well, now we want people to adopt it. But that's when we run into the problem that people don't view the problem the same way we do, almost guaranteed. They're either unaware of the risks, they don't think they have a problem, or they're unaware of the potential solutions. So how do you convince people to try out your solution to the problem they aren't aware of having? This brings us to what I said before, that really all communication is meant to affect behavior. And therefore, we have to understand the factors underlying the behaviors or the behavioral drivers. So this model, referred to as COM-B by Susan Michie and others, it's about 20 years old, so it's relatively new in our toolbox in health communication. But it suggests that it's a combination that a behavior, any behavior, is somehow dependent upon capability, opportunity, and motivation. And that sort of is easier to say than CMO, so we say COM. Capability is made up of both your physical abilities as well as your psychological abilities. You can read what some of those components are yourself. We're talking about opportunities. We're talking about time-bound instances of opportunity, as well as whether, the people that are in your important social set agree with that and you get an opportunity socially to do something. Maybe your environment is not supportive of it. And finally, with motivation, is it an intrinsic motivation that you just believe and feel that something is important for you to do? Or is it being reinforced or coming in from the outside that's creating this feeling that you want to do something? Now, by the way, all of the references that I'm making in this talk are linked in the slides, and you'll be getting a copy of that, I believe, or you can look at it yourself online. Now, COM-B is really complicated, and I will tell you how complicated in a moment. But I want you to remember that absolutely every crime story, novel, movie you've ever seen comes down to capability, opportunity, and motive. So if you want to remember what is involved in COM-B, just think about a true crime story and you'll have it set. Something that maybe more of us are more familiar with, because it's something that was out there ages ago, is the precede proceed model, but in particular precede. And most of us in health communication, public health communication, we spend most of our time in this phase 4, where we're trying to understand what we're called predisposing, reinforcing, and enabling factors. Taking a look at those, predisposing factors are pretty much what's in your head. So these are the things that, affect your cognitive rationale or motivation for performing a behavior. I like to say enabling factors are the things that are in your arms, has to do with whether it's accessible or available to you. It might also be where we classify the rules and laws, as well as your skills and your ability to perform something. Whereas reinforcing factors are really outside of you. They're the opinions of others, whether you feel that this behavior is rewarding, and it can even be your own attempt at performing a behavior and having some success. Like they say, nothing succeeds like success. That's a very reinforcing factor, which is why so much of the behavior change psychological literature suggests taking very, very small steps and receiving the fact that you can do something and then moving forward from that. So the COM-B model slices these factors somewhat differently, but the precede model gets us a little closer to communication interventions, which is only one of 93 interventions covered in the behavior change wheel. That's why I kind of like this one better a little bit. All right, so now we're finally at step 3 here in our planning process. And we're going to be coming up with some communication objectives. Now, you're going to be changing these into something much more specific, but at this moment, you're trying to determine if communication is your primary intervention or you're using it to support other interventions. And how that lines up with what I just showed you is if it's your primary intervention, you're mostly targeting those predisposing and reinforcing factors. And because they're primarily looking for people to acquire some sort of knowledge, an attitude towards something, or to be motivated to do something, as well as, of course, knowledge is an enabling factor because it gives people skills. But on a larger scale, when communication is supporting other interventions, you're really looking at policy, systems, environmental changes, and the communication is calling attention to those things or supporting their creation. If you're using communication as a primary intervention, then it's pretty basic in that we're looking at whether we can have people start using a product or a service, people start performing a behavior, or stop using a product or stop performing a behavior. And these examples will come from the CDC. For example, the Wash Your Hands campaign. This is from Let's Stop HIV Together. So using PrEP and using other prevention methods, or the Tips from Former Smokers campaign, which is to stop smoking, and here's some tools to help you do that. When we're really looking at individual change. For individual change to occur, it's really quite a psychological process. I'm sure you're all familiar with the stages of change model, but some of the things that as a health communicator, what we need to be putting out there is that people need to be aware of the need to change. They have to know what to do. They have to want to do that change. They have to feel ready to make it. They have to feel able to make it. They have to believe the change can be accomplished. They have to believe the change will be rewarding, and they have to believe that others will support the change. Now, there are theories connected to each of those pieces of what I say people need to think and feel. And of course, you're also thinking, because I just showed you that other slide, oh, that's capability, that's opportunity, that's motivation. But really, the whole package, if you just stop and think about yourself, what do you need to adopt any behavior that you tried to do? It could be flossing your teeth, it could be exercising more often. Just think of any health behavior you've tried to adopt and think about everything you really needed in order to adopt that. When we're looking at a community level change, it's somewhat different. We need to be thinking about the social norms and peer influences. We need to be finding who are the role models and leaders in this particular community. What are the group dynamics like? And how do we go about and organize people so that we have strong networks and incentives at a group level? This image, by the way, comes from Live to the Beat, which is a program that's tailored specifically for African American communities, helping them to overcome factors that prompt heart disease. All right, there are examples of interventions and communication support at each of these levels in the ecological model. And I know that this slide is kind of small. I'm just showing it to you and telling you where you can find it, which is in one of my textbooks, not to promote my textbook, but this is table 2 from there, so you know where it comes from. I don't expect you to be able to see this right now, so I commend you to look at this later and you can sort of see some of these examples. If you're at a state or a global level, the primary intervention will be some kind of policy or treaty. For example, in the US, the law requires us to wear seat belts in a moving automobile. But communication about that law is still necessary to keep people obeying it, which seems kind of crazy to me, but true. All right. A next step in our process model, again, we're still just in planning, is thinking about the relevant audiences. And in public health communication, we think of them this way. We think about a primary audience as the group of people who are most affected by the problem and whose behavior we're hoping to change. A secondary audience would be a group that has a great deal of influence over or control over the behavior of that primary audience. And a tertiary audience is a group that affects behavior of both or either the secondary or the primary audiences. And that becomes important because often we need to work with a group that we've identified as a secondary or tertiary audience. In other words, we're trying to reach children, or even we're trying to reach young parents. And we might need to enlist the help and support of healthcare providers, of spouses, possibly their own parents, possibly the clergy, if we want to try to influence them. And it might be important that those other audiences first make a change in what they're thinking and saying and doing before we ask that primary audience member to try to do something any differently. This really has a lot to do with individual agency as well as group agency. Some of us think about that as more structural or social determinants, but really there's always people that we need to be communicating with who can make a change that will facilitate one individual's behavior change. Secondary or tertiary audiences, especially now, could include social media influencers whom you either create or you buy. And the good news for those of us in public health who often don't have lavish budgets is that the micro influencers or small influencers often have the most authentic and appropriate audiences for the people that you're trying to reach. You don't really need mega influencers with millions of followers. Now, within each audience, there are even smaller groups that could be characterized by different factors. And we often use what we call audience segmentation in order to make our communications even more focused on one particular group or another. There are many different ways to segment audiences, some from very obvious things such as neighborhood or geography, but also it might possibly be cultural factors. It might be demographics, particularly age groups. A lot of the work done by Jeff Jordan around peer crowds has entirely to do with how young high school and middle school Kids sort of group each other up in terms of what music they listen to, what they believe is cool, and whom they hang out with. So there's many factors that can go into audience segmentation, and people don't, if we try to segment an audience, we're trying to make sure that it is unique and that it doesn't overlap another audience. Some other factors that we might use in grouping audiences has to do with where they are in their process of adopting a behavior. So in other words, people that haven't started thinking about it, we're going to treat differently than people who have already tried it once. This term psychographic factors really refers to cognitive factors like my attitudes towards risk. Like I'm a risk taker. I love to gamble. I love to go to Las Vegas. Not. I'm the opposite of that. Okay. I'm the kind of person who makes sure that I get up every morning and make sure my cats have eaten before I do. Okay, there's different kinds of people, and we try to ferret that out using marketing databases and such. So I know I'm going way off the deep end here. I'm going to keep moving along. We're up to this stage in our planning process, which is where we're going to choose what I call a core strategy of the kind of communication we're going to be using. Now, first of all, we're going to be trying to engage people. And this is really foundational to anything else we're going to try to do. Engaging has to do with capturing and sustaining the attention, the interest, and the participation of a particular group of people. It requires that we have some sort of meaningful interaction and that we build trust. Now, even if you just watch me on television every night or you listen to my podcast, after a while, I've engaged you, you're there. Even if you only lurk and you never post anything back to any of my social media, of course, that I'm putting out there to accompany those mass media tools, I might be trying to inform you. That would be answering questions. It would be meaningful to the person asking the question. And there's many tools that enhance an informing approach to health communication. And this is really where health literacy and numeracy and cultural competency come in to making sure that information is very understandable. And finally, the last stage or last kind of core strategy you might use is a persuasive one. And this could be coercion, it might be marketing, nudging. There's many different ways to go about it. How do you sort of decide which one you want to use? Well, Rothschild, who's used to be, I think he recently retired from the marketing department at the University of Wisconsin, he came up with a behavior management model, which I sort of adopted to look like this. And what it shows, sometimes I just call it the Wiener model. If we're looking at a change that we want people to do, if they perceive that the costs are low and the benefits are high for them, then simply informing people about it, educational approaches might be sufficient in order for them to adopt this behavior. And this approach really works best in a situation where someone's already expressed an interest or a commitment in a desired behavior, and they really want to know how to do it. Usually a person's looking for answers to factual questions. So this is not really a persuasive approach. We're trying to help people maybe make a decision, but we're not trying to push them in a particular direction of what that decision should be. If, on the other hand, to that individual, the costs of the behavior appear high to them and the benefits to them directly appear low, very often this is when states or municipalities have set up laws or regulations, which really are a form of coercion, saying if you don't do this, there's going to be some kind of a punishment for you. Now, communication is often used. I'm sure you've all heard the expression click it or ticket. Communication is used to try to make sure people are aware that those laws or regulations exist. But basically, that's the primary tool that's being used to try to drive this behavior change. But in between all of that is what we call marketing's domain. And in public health, it's really social marketing. And social marketing is a process where we work with the intended audience or the intended performer of this behavior in order to try to learn from them what will help them value this more, How do we raise the perceived benefits of the offering and lower the cost? The offering being the behavior that we want them to adopt, but it's not actually the behavior, it's the benefits of performing that behavior. So the whole goal with marketing or social marketing is it leads to voluntary adoption of an idea, a product, a service, or a behavior. Now, it can get confusing, I know, because nowadays there's a lot out there called social media marketing. And if you Google the term social marketing, 9 times out of 10, you're going to land on something having to do with social media. But for us, social media is that string and tin can that I showed you in one of the very first slides. It is a channel for reaching different audiences, but it can be extremely targeted and it has great value. So I'm not at all saying that we don't want to use social media. Of course we do, but in the right place and the right time for the right audience. All right, this slide, I'm sure you're all saying, boy, I thought the last one was crazy. This one's even worse. But I want to call your attention to this resource, which comes from a website called Spin Sucks, which is put out by Ginny Dietrich. And it has the public relations view of media channels, which I think is very useful to understand because the way that public relations people look at media channels is they look at, and this is called a PISO model, which stands for paid, earned, shared, and owned media. And so the media that you own, which is sort of over here in this small font over here, could be your own website, your blog, your podcast, and other things that you produce yourself. Paid media is anything you purchase to carry your content, which includes paying influencers on social media. Earned media used to be only when the news would pick up a story, or there might be public relations channels that will carry stories for you, which you are now generating about your work. In other words, it's getting out through some sort of mass media channels or other channels, but you haven't had to pay for them. In contrast to shared media, which are really like, for example, LinkedIn or other ways that we share media across channels, but we're not having to pay for them or we don't own them ourselves. So somebody else posts something for you. In a sense, when you quote go viral, you've had a great success with your shared media. I'll give you another way, though, to think about media channels, which might make it a little bit less chaotic. And it has to do with your priority audience or your primary audience is what we call customer journey. If this is healthcare, we might call it a patient journey. And this one gets to be a little bit it's got 2 layers to it. I'm just showing you the commercial marketing version of a customer journey map because commercial marketers take the perspective that people become aware of a problem and then they try to solve it through the acquisition of a product or service. And you'll see that they think it moves through these phases of becoming aware, considering different options, making a decision, and then using something, and then possibly, if they really like it a lot, advocating to friends about it. It maps along somewhat with the stages of change where we haven't thought about something at all, and then we become aware of it, and then we start looking at different ideas. We might try it out, and then we adopt the behavior, which is like buying the product. And then if we get really into it, we might start advocating for it with our friends and relatives. So we have this journey. It's both tangible and intangible. In other words, in our head, as well as if this were online searching, you can see how you would go through these various phases. But if you're thinking about a target audience or an audience that you're trying to reach, we also know that along this journey are ways that we can reach out and touch somebody, and those are called touch points. And those touch points can be mediated. So if we truly understand a process that somebody is going through and they're thinking about adopting a behavior, and we have a sense not only of where they're at, mentally, but also how they travel through space and time as they go about their day, we can place media prompts or touch points across that domain, and some of them will be more effective than others. So that is a way of mapping out where you're going to be selecting which media channels and why. And this all goes back to having a very deep and thorough understanding of your audience, their lives, and where they're going to be. Okay, we've finally gotten to actual messages. Are you shocked that it took this long to get here? Because I know so many other sites start with messaging, and to me, it's impossible to develop messages without thinking about the audience, the behavioral drivers, or even the channels on which I'm going to be disseminating that information. So we really need to start with what I say are concepts. And the concepts are larger concepts, larger ideas in your head that maybe you can convey in images and even in some words. But I'm kind of finicky, and that I like to use the word message for those actual words and images that are going to be communicated in my materials or whatever it is that I'm trying to put out. There are many ways to come up with your messaging, and one very popular method these days is called framing. And just to sort of give you just the most basic gloss on framing, it's picking which words you're going to emphasize to explain an issue and what you're not going to say in a particular message so that this audience interprets the information in a particular way. So going back to what I said were WEO's laws, you are trying to cut down on an audience taking the wrong interpretation or the wrong understanding of something by how you're framing that message. A lot of framing involves prospect theory, Kahneman and Tversky, if you know about that. And maybe the most simplistic version of it is when we do gain frame messages or lost frame messages. So a gain frame message is putting forward the benefit. Getting your flu shot helps protect your family and keeps your community healthy, versus lost frame. If you don't get that flu shot, it increases your risk of severe illness. You're going to miss school or work. And you realize a lot of this came up during COVID. You could see people trying out these various frames of the messaging, and it's not like one size fit all at all. These messages really had to change depending on for who was getting that message, the time in the pandemic, et cetera, et cetera. You can see a whole lot more about framing at the Frameworks Institute website, but they have a project that was called Phrases, which had to do with how we frame public health itself in communication, and there's a website for that there. All right, in my planning process, I have recruit partners at this stage. Of course, you might have recruited them right from the very beginning. And if you're using a cooperative or a collaborative form of message development, of program development, your partners would be part of the process right from the beginning. But what I want to emphasize is that partners shouldn't be picked randomly. You really would want them to have something at stake, which is why we often call them stakeholders. What's at stake for them might be their lives. They might, for example, they might be a patient group. They might have their health at stake. They might have their reputation or funding, and it depends on the success of the program. So they really want the program to work. And then you might ask additional partners to join based on their access to and reputation with a particular audience. Maybe they have certain resources, including certain skills. So the process of bringing partners into a health communication intervention, it requires strategy and thought as much as any other piece of this. All right, moving right along, we're now thinking about how are we going to know if this works? So we're planning our evaluation. Now, of course, in public health communication, we're going to have SMART objectives. You've all learned that to death. Some of the things we'll be looking at are the process of it. Have our messages been distributed the way we planned? And did they reach the intended audience? Did we see the intended behaviors take place? Do we want to worry or predict any unintended effects, either good or bad? And do we need to revise our plans in order to achieve the objectives? One of the things that is often overlooked in doing public health communication has to do with audience reach. And this is what has to do with distributing the information. Bob Hornick back at Annenberg quite some time ago, and I really haven't seen this bested or updated, after analyzing many campaigns, determined that unless you've reached about half of your intended audience, you shouldn't expect to see any other outcomes from it. In other words, if you haven't gotten that information out there to at least half of your population has heard it, you're not going to get any changes in beliefs, attitudes, or outcomes. It would only be in a very small group. Now, I didn't talk at all about, diffusion of innovation or any of those other theories. They're all relevant here, but reach is sort of the three R's of public health communication. All right. Then you need our last step, we're still in planning, is developing an implementation plan. So that's your basic major activities, your timeline, and who's going to do what when, and have a budget for it. And you put it down on paper or whatever task management software that you like. And that's it. Now you have a plan of how to deliver a health communication program. I know that was a whirlwind overview, and I can't obviously put all of health communication into a 40-minute talk or whatever this is, but I do want to share some wonderful resources with you where you can get pretty much all of the details pertaining to the things that I've talked to you about. So, for example, if you are very interested in global work, there is UNICEF and former USAID funded programs have extensive materials posted online. For example, Johns Hopkins Center for Communication Programs for decades has been producing materials and tools and approaches. You can see this is their social and behavior change implementation kits for various things. There is a campaign in a box toolkit that comes from, this is from a USAID funded program. There's lots of great stuff out there, lots of resources. The Society for Health Communication has been around now for about 10 years. It offers free membership for anyone interested in health communication. And in addition to having access to hundreds of professional health communication experts through that society, if you join now for free, you can get our leading journal, one of our two leading journals in the field, for $10 a year, which is sort of unheard of if you don't have access to it through a library, an academic library or a public health library resource. That is a fantastic deal. So for free, you get a journal that, normally costs hundreds of dollars. You can get it for $10. Another amazing resource right now is the Public Health Communications Collaborative. It was set up by the de Beaumont Foundation during the pandemic with assistance from CDC Foundation, Robert Wood Johnson Foundation. It has lots of trainings. It has a whole course in how to do strategic communication, as well as other forms of public health communication that you can take and be credentialed from there. They also have very specific messaging packages and materials that they put up. So that is something that's very helpful and very useful. And of course, I mentioned right at the beginning, this standard, doorstop at this point, but so much of it is still relevant, which is the National Cancer Institute's Making Health Communication Programs Work, which you can get. I've linked the website in the notes for this slide. And believe it or not, you can still access CD Synergy with this QR code here. It's at the Oak Ridge site, Oak Ridge Institute for Scientific Exchange was CDC's partner in producing CD Synergy. And even though the Adobe Flash no longer works, you can really go step by step through all the phases and steps that CDC thought was important in planning a health communication program. So last but not least, I would be remiss if I didn't mention that the University of South Florida and the College of Public Health, we do offer a social marketing certificate. We have courses that you can take either stand alone or you can apply them and earn a certificate, a graduate certificate, which can then be used in any graduate program pretty much anywhere if they accept those credits. So that is it. And I'm here to answer questions if anybody has them.
Hi, it's me again. One of the questions I see, and don't forget if you have any questions, please add them to the Q&A section. But Robert wanted to know if he could get the name of the journal again, the one that's for $10, or I suppose how to get that.
Yeah, well, okay, you can get the journal itself at the Taylor and Francis website, but let me just pop this up here again real fast. So it's the Journal of Health Communication International, oops, the Journal of Health Communication International Perspectives. There is another Journal of Health Communication, but this one is uh, it's called Journal of Health Communication International Perspectives, and you'll see that the most recent issue of it has a logo from the Society for Health Communication on it. In the slide, it will show you how to get it. I guess that's probably the easiest way for me to say if you don't want to just go Google Taylor and Francis Journal of Health Communication International Perspectives.
And I will be sending out a link to these slides when I send out the recording, which should be in the next 24 hours or so. Yeah, this was great. In terms of any questions, here's
It's a bit of a
one.
fire hose. I know it's a bit
I
of a
know.
fire
Everybody's like,
hose.
is my lunch done yet? You talked about the challenge of reaching audiences who don't see a problem or don't believe they're at risk. Based on your experience, what's most effective when people don't yet agree that a public health issue applies to them?
Well, you have to figure out where they're at as opposed to where you want them to be. Uh, which means that you start talking to them about what is important to them and what they're hoping to achieve in their life or for their children. And you have to figure out how does this relate to what they're trying to achieve. So again, I would put my social marketing hat on and try to determine from them how do I link what it is that I'm offering to something that they value.
Mhm. Right. And then another question, as language in public health continues to be censored, how do you advise navigating this new challenge?
Okay, well, that is that whole framing thing. And I know that there's a lot of effort going into figuring out how do we say something not using terminology that we learned in public health, for example, social determinants,
Mhm.
and trying to find wording that resonates with the audience that I'm trying to convince. What is more important to me? It's not to use specific words, it's to try to get an idea adopted. And if I really do my job well, the people I'm talking to will think it's their idea as opposed to me putting the idea in their heads. So I don't think I can stress enough. It's getting to know an audience and how do they describe things, and then trying to use that language to describe the issue that I am trying to bring up to their attention. Now, I don't know how you work with people who truly have their values are so different
Yeah.
from public health values. I think that you just have to look at the data and know there's a diffusion curve, as I mentioned the diffusion curve before, and that even though the media does tend to look for conflict, look for tension, that is what makes stories interesting, it's probably still a minority opinion. And can you get people that are in what we call a movable middle to reach back and pull some of those people over? You really want to be working with people that are just ahead of the middle, whenever you're trying to convince people to adopt something. Not the people all the way over to one extreme side or the other, but you're trying to go just a little bit to the right of the middle in terms of an adoption curve, because then they can bring everybody else behind them along, except for that last 5%. You're not going to get them. You just have to control them and keep them from being too deleterious
Mhm.
to your efforts.
We do have a couple more questions right now. One I think is in reference to what we were just talking about, which is, can this be applied to working with providers that are experiencing burnout?
Well, providers experiencing burnout need more than communications to not be burned out. And yes, I would say if you're also finding structural supports and things that need to change, which again is why, while I'm speaking to you today about public health communication, I really advocate for social marketing, because we have to look at what is bigger than just the communication. What else needs to change? And do policies need to change? Do structures need to change so that people's jobs and lives can be rewarding to them? You can't just talk your way or communicate your way out of a structural or a policy problem.
Yeah. And two questions from Megan that also play off of this, and I'll ask them both together, which is, where does motivational interviewing come into play? And then, do you have any resources related to using this approach with overdose prevention?
Okay, so motivational interviewing, I will say, is an interpersonal and psychological therapeutic kind of health communication, which, because it's so one-on-one and interpersonal, it's not something that I'm really speaking about today, because I'm speaking more about public health communication and development of public health communication programs or interventions. Motivational interviewing is something that takes a lot of skill. I don't think it's something that you can just, pick up quickly. And it's really used in a one-on-one setting for the most part, because it's so interactive. So I'm not the expert on that, and hopefully you have other people who could talk about that. So with overdose, yeah, I'm not even going to go near that. That's so outside my expertise. Sorry.
That's a fair answer. Better to not answer than to throw it to the
Mix
wind.
something up, right? Yeah, yeah.
Um, that is all I have right now for questions. Anybody else? Looks like we're going to end on time, Claudia.
Well, you have an amazing series lined up. I'm looking forward to watching a lot of the other sessions, and I hope this just kind of gave you a taste of, what I think is foundational, fundamental to public health communication, which is really the planning.
Yeah.
So,
Thanks. It was really a great presentation. A lot of comments in the chat say the same thing. So I really appreciate your time. And if anybody wants to see the rest of the series, again, it's on our website, deltaomega.org/prof.dev. So we'll hope to see you at the next one. I'll get this recording and the slides out to all of you in the next 24 hours or so. Thank you so much. And thank you, Dr. Parvanta.
thank you. Bye.
Bye.